check, check. Okay. All right. I guess it is audible now. Is it audible now? Is it audible now? Can you all hear me? A quick feedback. Audible? Great. Chalo. So we're starting with the session here. I'll be starting with the first question. This is all your previous year questions of your INI. So we're not going to emphasize ki yes, ye tha, wo tha and all that. So let's do a quick recap. Now, child presented with the cleft lip. ठीक है. Our child is presented with the cleft lip, planned for repair. Which of the muscle will be repaired during or first during the surgery? ठीक है. Now, when you look at the muscles that are being given to you, the orbicularis oris, right? That is around the lip. So yes, you can repair it. Oculi is around the eye. Zygomatus major is lateral to it, not important. Levator align nasi is going to be in the center of the septum. So again, it is not important. So the muscle which will be repaired, in fact, the muscle which is to be repaired in this is going to be A for Ahmedabad. That is your orbicularis oris, right? Now, for this cleft lip and cleft palate, there is rule of 10. I hope everybody knows it. This is again very commonly asked in our INICET exam. What is that? The age of the baby should be around 10 months old. There should be at least 10 pounds of weight gain. There should be 10 pounds of weight gain should be present in this baby. And look at this, the hemoglobin should be 10 gram%. If these are satisfied, these kids are ready. Bhargav, I got it. I will update the team. I'll do that, beta. Today only we'll do it. Chalo. Now, along with that, what is the repair time and the repair criteria that you look at it? The repair time or the repair criteria in a cleft lip and a cleft palate. A quick recap on that as well. If a patient is having a unilateral cleft lip, if there is a unilateral cleft lip, the repair timing is going to be between 5 to 6 months of age. If bilateral cleft lip, then you are going to decrease it by a month, around, sorry guys, around 4 to 5 months. Okay? If the patient is having a cleft soft palate, then it is going to be 6 months. For hard palate repair, for the hard palate repair, it is 15 to 18 months, right? So this is the entire repair criteria for each individual component that you should be aware of. Okay? Discussion, we are with you for, okay, got it. Chalo. Going on to the next question. I have a 65-year-old patient on a mechanical ventilation for ARDS. Okay. Suddenly, the patient develops hypotension, tachycardia, absent breath sounds on the left side, trachea deviated to the right side. So, absent breath sound on the right, on the left side. So, breath sound is absent on left side, trachea deviated to right side. So, I can say it is your left-sided pneumothorax. It is a left-sided pneumothorax. And why would a patient develop a left-sided pneumothorax in an intubated patient? So on a mechanical ventilation, if the pressures are high, it can result in pneumothorax because of barotrauma. So on ventilator, the patient will develop a pneumothorax secondary to severe barotrauma. If the PEEP is high, it can cause it. So it is going to result because of barotrauma. So pneumothorax is here purely because of the barotrauma, right? So you are asking for the components. The trachea is the, what is the likely cause? It is not because of the high tidal volume. It is due to barotrauma because of high air pressure is correct. Not because of ET malposition or oxygen toxicity. Here the answer is going to be severe barotrauma that has resulted in this context. Absolutely correct. Now, when you talk about the pneumothorax, we all know the tension pneumothorax and the open pneumothorax are two different components. Just for the sake of understanding, for emergency needle thoracocentesis, for emergency needle thoracocentesis, for the emergency needle thoracocentesis in adult, where would you like to put? And in a child, where would you like to put? See, in either cases, the preferred size of the needle is going to be 14 gauge. In adult, I would like to put in the 5th intercostal space of the mid axillary line. Here it is going to be the 2nd intercostal space in the mid clavicular line. In the mid clavicular line. But if I say what is the definitive one, as most of you know, definitive is going to be an ICD insertion. Now in the INI, they are very peculiar or particular about how or ICD size that you're going to put. Remember, the size of the ICD that we are going to put in the adult is going to be a 28 French, and in a child we'll prefer an 18 French. ICD insertion is done in a safety triangle. ICD insertion would be done in a safety triangle. Now the safety triangle, if you look at this, in the triangular boundary that you have in the safety triangle, the boundaries that you have in the safety triangle, anteriorly it is formed by the pectoralis major muscle, posteriorly by latissimus dorsi, inferiorly by the 6th rib. Inferiorly by the 6th rib. So these are the contexts that you will look in terms of ICD placement. Going on to the next question that we have. Which of these is the most life-threatening injury that can be identifying the assessing the breathing component of the patient, right? By breathing component of the patient. Now, cervical spine injury cannot be assessed by breathing component. Cervical spine injury is assessed by the nexus criteria. Nexus criteria is your national emergency. It's a national emergency X-ray utilization study. It's a national emergency X-ray utilization study. Tension pneumothorax, yes, it can be assessed on the breathing component. Blunt cardiac injury can present to you with pericardial tamponade. They can present to you with pericardial tamponade, and that is going to present to you with Beck's triad. Now, in the Beck's triad, what do you have? You have hypotension. You have hypotension, raised JVP, and muffled heart sounds. And muffled heart sounds. And muffled heart sounds. So nowhere it is mentioned for respiratory status. So again, it cannot be assessed. The laryngeotracheal injuries, again, it is not the breathing component, it is the airway component that you can assess. In laryngeotracheal injuries, it can be associated with stridor, right? There is presence of stridor, or there can be presence of subcutaneous emphysema. So if you look at the injury that most life-threatening, when you look across, that can be assessed. So in the context of these two injuries that we have, see, with the breathing as the component, I can assess tension pneumothorax and the laryngeotracheal injuries, right? But if you look at these two, which is more life-threatening, the answer is tension pneumothorax. So answer here is going to be tension pneumothorax. Now, usually when they ask you about the immediate life-threatening injuries, right? Okay. So what are the injuries which are considered to be immediate life-threatening in thoracic injuries? We have the immediate life-threatening, injuries. So we have deadly dozen. Out of the deadly dozen, when you look at this, the immediate life-threatening injuries, I can categorize them as 6. And they can be remembered by a simple mnemonic, that is ATP TOM. So our Tom and Jerry in Tom has a lot of energy. So ATP TOM. ठीक है? Beta, adult में needle thoracocentesis is done at 5th and in child it is done in 2nd. That has been updated long ago. ठीक है, चलो. Now A stands for the airway obstruction. It is an airway obstruction. T stands for tension pneumothorax. T stands for tension pneumothorax. P stands for pericardial tamponade. P stands for pericardial tamponade. T stands for tracheobronchial injury. It is a tracheobronchial injury. O stands for open pneumothorax. O stands for open pneumothorax and M stands for massive hemothorax. M stands for massive hemothorax. These are your immediate life-threatening injuries, right? So in deadly dozen, you have immediate and potential. So these are all the list of immediate life-threatening injuries, right? Going on to the next question that we have, I have a 32-year-old female presents with breast lump, okay. Mammography suggestive of carcinoma of breast, okay. Her aunt had the breast cancer, died at the age of 45. So family history of breast cancer is present. And 29-year-old sister can afford only one screening test. Which screening test should you advise? So for all patients of familial breast cancers, we are going to advise for BRCA mutation. So if they can afford only one test, the standard and the strongest recommendation that I would give would be of BRCA. So hence, when you look at this, there is no option, I mean, controversy here. It is BRCA mutation, right? Now, there are a lot of things they'll ask you with respect to BRCAs. We'll quickly run through them also. There's something called as if the BRCA mutation is positive, you see that is hereditary breast ovarian cancer syndrome, HBOC syndrome is present. Now, all patients who are suspected of HBOC syndrome, their BRCA mutation will be positive. If the BRCA mutation is positive, then you have to screen all first degree relatives. Screen all first degree relatives. Now, after you have screened the first degree relatives, you see if any of the relative is positive for mutation. If any of the relative is positive for mutation. If the relative is positive for mutation, you will see whether the patient, after you have seen whether it is positive for mutation, you will see whether the patient has completed the family or incompleted the family. So family status, we say if the family status is complete or if the family status is incomplete. Family status is complete or incomplete. If the family status is complete, then we'll ask for risk reduction. Advise the patient for risk reduction. In risk reduction, we do bilateral mastectomy and bilateral salpingo-oophorectomy. Bilateral salpingo-oophorectomy. On the other hand, the family status is incomplete, then I will see the age of presentation less than 25 or more than 25. Less than 25, do nothing. More than 25 years, you do MRI on an annual basis till she completes her family. It's an annual MRI till she completes her family, and this is what you're going to do with respect to HBOC syndrome. Okay? Yes, very important. So hereditary breast ovarian cancer syndrome is like one of the prime questions that INI people love to ask. Okay? Going on to the next question that we have. Okay. So next question that we have, I have a 37-year-old unmarried nulliparous woman, okay, having regular intercourse. She is on OCP, ठीक, right? Mother was diagnosed with carcinoma of breast at the age of 60 years. Her elder sister was diagnosed at ovarian cancer with 40 years of age. What is the next line of management? Now, she is a candidate. We just learned about HBOC syndrome. So, they are actually positive for BRCA mutations, right? So, you will actually screen for BRCA mutations. So we have two BRCA gene, BRCA1 and BRCA2 gene mutation. When you look at the comparative data between these two, now the first thing you will see that they are associated with chromosome number 17q for BRCA1 and chromosome number 13q to BRCA2. Now here in BRCA1 the receptor status is usually negative and the receptor status in BRCA2 is usually positive. So hence they have relatively a better prognosis, right? They have relatively a better prognosis. Now they are associated with other malignancies, like for example, they are associated with female breast cancer. They are associated with ovarian cancer. They are associated with male breast cancer. They are associated with prostate cancer. They are associated with prostate cancer and pancreatic cancer. So these are the other malignancies that they are actually associated with. So female breast cancer is more with BRCA1 when compared to BRCA2. Ovarian cancer is also more with BRCA1 when compared to BRCA2. Rest, male breast, prostate and pancreatic, the incidence is higher with BRCA2 when compared to BRCA1, right? Now, because there's a very strong family history of breast ovarian cancer syndrome, I'm predicting that the patient is having a HBOC syndrome or BRCA mutation. So in this patient, I would definitely want her to go with a genetic counseling for screening for BRCA. Routine mammography, no, she is high risk. Even if you want to screen, it is going to be MRI. It is not going to be mammography. OCPs per se do not contribute much in general. If it is an estrogen only pill, that can contribute a little bit. Otherwise, per se not. Prophylactic surgery is only done if the gene mutation is found to be positive. So first do the genetic testing, confirm it, and then go with the same, right? Chalo. So finished. Okay, to number it, no, I think this is question number 5. So we go to question number 6. So this is question number 6. Which of the following does not come under breast cancer T4B, right? Everybody knows it. A quick recap: T4B is basically involvement of the skin. How do you know the skin is getting involved? The skin involvement in breast cancer: number 1, presence of PYQ orange. Number 2, if there is presence of ulceration. And number 3, if there is presence of satellite nodules. If there is presence of satellite nodules. So if there is presence of PYQ orange, ulceration or satellite nodule, will consider to be skin involvement. As a note point, remember, dimpling does not alter. Dimpling does not alter the staging. And as most of you know, dimpling is due to involvement of Cooper's ligament. It is due to involvement of Cooper's ligament, right? So, which of the following does not come under 4B? Ulceration comes, PYQ orange comes, satellite nodule comes. Erythema, more than 1/3 is your inflammatory breast cancer. It is your inflammatory breast cancer, and this will come into T4D. This will come into T4D, right? This will come into T4D. That's a question number 6. Going to the next question, that is question number 7, right? I have a 6 weeks old baby presented with non-bilious, non-projectile vomiting for past 3 weeks. Okay? On examination, abdomen is unremarkable. What is the likely diagnosis? And this was the controversial question that was popped in the last session of INI. Now, if you look at the following one, usually when you see 6 weeks old baby vomiting, you think about CHPS, that is pyloric stenosis. But the problem with pyloric stenosis, you'll see that this is going to have non-bilious vomiting. So the first point is correct. But this non-bilious vomiting will be projectile in nature. So it will be a projectile vomiting. It will be a projectile vomiting. Now, this abdomen cannot be unremarkable. In the abdomen, there will be presence of olive lump. There's presence of olive lump and there is visible peristalsis. There will be visible peristalsis in order to call it as congenital hypertrophic pyloric stenosis. So here it does not appear to be that. Yes, GRD of the kid can cause it. The early onset of GRD can result in milk allergy. They will more have diarrhea rather than vomiting. Intestinal obstruction will have colicky abdominal pain. Obviously, the baby will have extensive non-passive stools and flatus. All that abdomen will get distended. You can't have unremarkable abdomen in intestinal obstruction. So logical answer to this question is going to be your GRD, right? CHPS, yes, it will be seen between 3rd to 6th week of birth. Single best answer is going to be 4th week. I'm not shying away from it, but then this case does not appear to be of CHPS. It is classical for a neonatal GRD. Going to the next one, that is question number 8. In the question number 8, what do you have? A patient presents to you triage after a road traffic accident, a GCS. Okay, the minute you see the GCS of 8 by 15, remember GCS will less than or equal to 8 by 15 increases the risk for coma. Hence, it is an indication. It is an indication for intubation. It is an indication for prophylactic intubation. Now, focal neurological deficit is present. On examination, right-sided breath sounds are absent. So, probably there is pneumothorax as well. There is pneumothorax as well, which is the next step in the management. Now, CT head, again, so GCS is less than 8 by 15. I don't want to get the CT done. I need to secure the airway first. So, hence not this. Secure IV line and transfusion, no concepts of this. See, you will get confused between ICD and securing the airway. Now, if you put an ICD, what are you going to achieve? You're going to allow the air to go out, lung to expand. But at the same time, again, the ventilation has to be managed. If you secure the airway and then do all that, you'll have better opportunity for saving the patient. So airway, so that is one in protocols also. If you look at this, what is your primary services? That A, B, C, D, E is the order, right? So I will give airway priority over breathing. So here airway should be given priority over breathing. So hence the answer here is going to be D for Delhi. It is going to be D for Delhi, right? So there is no point for guessing here also. Going on to question number 9. This is again their famous exam question. The image of the Z-plasty is shown in the procedure. What is the main use for this surgical technique? Now remember, Z-plasty is basically performed for 2 reasons. Number 1, to increase the length of the scar and to release wound contracture. It is to increase the length of the scar and to release wound contracture, we do Z-plasty, right? So yes, increasing the length of the scar is correct, not for flap turning, not for cosmetic camouflage, not for muscle release. So answer A is correct. Now, how much length will you be able to increase by doing this, right? So in the Z-plasty, based upon the angle, if the angle is 30 degrees, the increase in length is by 25%. If the angle is 45 degrees, the increase in length is by 50%. If the angle is at 60 degrees, there will be increase in length by 75%. And if the angle is 90 degrees, there will be increase in length by 90%. Right? So the gain in length depends upon the angle. Then that angle we are talking about is this. It's talking about this angle. So based upon how much is the angle at the level of Z-plasty, this angle will determine, or I can say this angle will determine how much the gain in length will be present. Going to the next question, we have question number 10. In the question number 10, which of the following is not a contraindication for breast conservative surgery? So to understand not a contraindication, that means what is the indication for breast conservative surgery? Number 1, for a breast conservative surgery, it should be less than 4 centimeters in size. It should be limited. It should be limited to one quadrant. it should be a solitary lesion. It should be a solitary lesion. Less than 4 centimeters, limited to one quadrant, solitary lesion. No evidence, there should be no evidence of lymphovascular spread. There should be no evidence of lymphovascular spread, and patient should be non-pregnant. Patient should be non-pregnant. Okay. जो बेटा नीट यूजी का प्रिपेयर कर रहा है, विशिंग यू ऑल द बेस्ट सो दैट यू क्रैक एंड सी अस बैक इन द मेडिकल एजुकेशन. ऑल द बेस्ट गाइस. Chalo, not a contraindication for breast conservative surgery, right? Now, when you look at the certain components here, connective tissue disorders like scleroderma, they flare up by giving radiotherapy. So hence it is contraindicated, because breast conservative surgery per se, no. The breast conservative surgery is basically wide local excision with radiotherapy. Without radiotherapy, you cannot call this as breast conservative surgery. The reason patient should be non-pregnant, because the radiotherapy is contraindicated in the pregnant females also. Now, previous history, or we can say previous radiation to the chest wall. Now, when you look at previous radiation to the chest wall, already would have caused fibrosis, and in that way, the another attempt of radiotherapy won't give you much of an yield. Tumor limited to one quadrant, yes, as you can see, it's limited to one quadrant, it fits it. Persistent positive margin after repeated excision, that indicates the most extensive disease or more extensive disease, hence cannot be done. So answer here is C for Calcutta. For your exam, just remember these indications, these are more than enough. Going to question number 11. Which of the following is incorrect regarding negative pressure wound dressing? The old name for negative pressure wound dressing was vacuum assisted closure. It is your vacuum assisted closure. So when you look at the vacuum assisted closure, what do you know? Number one, it has got a pressure of minus 125 millimeters of mercury. It is to be put on intermittent basis. The pressure works on intermittent. So there's an intermittent pressure. There's not a continuous negative suction pressure. The advantage is dressing to be changed. Dressing to be changed after 5 to 7 days. So if you put once whack, the next dressing is going to be after 5 to 7 days. It increases the proliferation of granulation tissue and also keeps the wound dry. Keeps wound dry. Right? So these are the advantages that you have. So which is incorrect. Now the first option, dressing to be done in 5 to 7 days, is correct. Increases the proliferation of granulation tissue is correct. Can be continuous or intermittent. When you talk about can be continuous or intermittent, yes, it is an option that you can have. The pressure is not 10 to 20, it is minus 125. So yes, the answer is going to be D. Usually we put it as an intermittent pressure, not continuous, but yes, it can be switched between both if required. So here pressure is not 10 to 20, it is minus 125 millimeters of mercury. Going on to question number 12. Now, in the question number 12, I have a 30-year-old female presented to the emergency department with burn injuries involving the face. Now, I can say if the face is involved, I'm going to take 9%. Both the upper limbs. So, each upper limb is going to be 9%. So, you're saying both the upper limbs. So, I can say upper limb together is going to be 18%. Anterior chest. Now, we have something called as trunk. Trunk is chest plus abdomen. Now, chest plus abdomen together is 18%. So, I can say 9% chest and 9% is going to be abdomen. Anterior is this, posterior will be of the same value. So, here the chest is involved. So, 9% of the face, 18% of the bilateral limb, 9% of the chest again. Calculate the total body surface area burnt. So it is going to be around 36%. No, 18 plus 18 is 36%. So our calculation says it is 36%. It is a 36%. So that goes into option A, that is between 33 to 36%. Okay. So this is how you calculate your Wallace rule, right? If they ask you The most common rule assessed is going to be the Wallace rule. That is also called as the rule of 9. And if they ask you the best, then it is the Lund and Broders chart. It is the Lund and the Broders chart, right? So this is with respect to burns. Going on to the next question, that is question number 30. We have an ER positive used. Some power outage. Give me a second, guys. I think we're back on, so not an issue. Just give me a second. Chalo. Yeah, we'll simplify the GCS also, but don't worry. Now we have a ER positivity is used as the following in the context of the breast cancer. So ER here, estrogen receptor. Now receptor positivity, we use it in one of the criteria which is called as the luminal criteria. Luminal criteria is basically a criteria for prognosis. It is the criteria for prognosis. Now the characteristics that you will see is going to be the estrogen receptor, the progesterone receptor, and the HER2 neogene status. In luminal A, you will see ER, PR positive, HER2 neogene negative. In luminal B, all three of them will be positive. In basal cell type, all three of them are negative. And in HER2 neotype, these two are negative, but HER2 neogene is positive. Now, luminal B is called as triple positive breast cancer. It is your triple positive breast cancer, and basal cell is triple negative. It is your triple negative breast cancer. If they ask you what is the best prognosis, luminal A has the best prognosis, and the basal cell, which is triple negative, has the worst prognosis. So when you look at this context, so ER positivity is used as one. It is going to be used as diagnostic, prognostic markers, but ER positive will also determine if the receptor status is positive, I will give hormonal therapy. If the ER status is negative, then I will give chemotherapy. Now there are two things which are determining. So if you look at the luminal criteria, it is designed against the receptors. But we say the prognosis depends upon the receptor status being positive or negative. Now why? Because if the receptor is positive, you can give hormonal therapy. If receptor is negative, you have to give chemotherapy. So what are you trying to decide? That on the receptors, we're trying to decide the treatment protocol, right? So let's look at the options. Is it a diagnostic marker? No. Is it a prognostic marker? Yes. Is it a surrogate molecular marker? No. It decides treatment? Yes. So if you have to look between prognosis and treatment, it is prognosis depends upon the receptor status based upon its treatment protocol. So hence answer here is going to be D for Delhi. It's going to be D for Delhi. Moving on to the next, that is question number 14. Let's look at question number 14. I have a 44-year-old female presented to the surgery OPD with the complaints of ulceration on the skin. So when you talk about ulceration of the skin, okay, you're probably thinking about invasive ductal cancer. You're talking about the breast cancer. So you have a patient with ulceration of the skin, inflammatory signs on the right breast. Nipple retraction was also noticed. Patient diagnosed with invasive ductal cancer. Identify the stage, right? Now he's saying there is ulceration. Ulceration of the skin basic indicates there is involvement of the skin, and skin involvement is T4B. I said, okay, fine, not a problem. There's inflammatory signs. If there is an inflammatory breast cancer, if there is an inflammation, it will become T4D, provided it should be more than 1/3 of the skin. Nipple retractor will not actually alter. I'm identifying that N is 0. So he's saying if I have to take it as T4D, N0, M0 is your final verdict. And based upon this, you have to predict the stage. Now, I know it is very difficult for you to remember the staging. So, I'm going to give you a ninja technique to remember the staging in breast cancer. The ninja technique is, for a stage, you'll confuse between 3A, 3B, 3C. How do you identify 3A, 3B, 3C? If there is an N2 disease, it is 3A. If it is a T4 disease, it is going to be your 3B. And if it is going to be N3, it is going to be 3C here. Now, if you look at this, our disease is a T4 disease. A T4 disease indicates 3B disease. Answer is going to be stage 3B. It is going to be stage 3B. You follow this, you will never go wrong. You don't need to remember the entire staging protocols. Just remember, if the disease is N2, it is 3A. If it is T4 N2, because T4 is higher, it will become 3B. If it is T4 with N3, N3 is higher, it will become 3C, right? So N2 disease is 3A, T4 disease is 3B, N3 disease is going to be 3C. So hence, based upon this, you can simplify it. Okay? So, going to question number 15. Which of the following is not done in primary survey of trauma? So primary survey of trauma, the goal is to rule out any immediate life-threatening injuries. To rule out any immediate life-threatening injury, and that too at the earliest. Okay. Now we know the primary survey protocols are A, B, C, D, E. Now, if you remember in airway, did we do any investigation? So, airway does not consist of any investigation. It's only clinical assessment. Max to max, you can get an X-ray of the cervical spine, nothing else. So, yes, in airway assessment, I can go with X-ray. For breathing and ventilation, for pneumothorax, I would get an X-ray done. On an emergency, I'll get an ultrasound done. For circulation, we don't do any investigation. It is going to be basically to measure your system, your blood pressure and heart rate, and nothing more than that. D is a disability limitation. Disability limitation is basically done on the GCS scoring, not on the basis of CT scan. So here, CT is done in secondary survey, not in primary survey. You rely on disability limitation only on GCS. Expose and examine is again a clinical component, nothing more than that. So what are the modalities you have used? You have X-ray, you have used ultrasound or GCS, nothing more than that. CT will not be done, X-ray can be done. In airway, I will intubate, and in emergency procedure for airway maintenance, that is for breathing and ventilation. If there is a pneumothorax, I'll put ICD. That is what we do in a primary survey. As I told you, CT is a part of secondary survey. CT is a part of secondary survey. Question number 16. So what is question number 16? In the question number 16, what do we have? The primary prognostic factor that signifies the influences the outcome of breast cancer. Now, if you look at, they're asking for prognosis. The prognosis of the breast cancer, number one, depends upon the stage. If this is not in the option, then it depends upon the lymph node status. If this is not in the option, then it is the size of the tumor. Then it is the size of the tumor. So what is the primary prognostic factor? Is it the lymph node? Is it the metastasis? Is it the size or the receptor status? When you look across here, size is the last one. See, it depends upon the lymph node status. Distant metastasis is M1. M1 basically indicates that is a stage 4. So talking about this is the stage of the disease. Size also, it does not depend on receptor status. Receptor status will tell you about the determining of your treatment protocol, whether you're going with hormonal therapy or not. Okay? So if you look at this, these are the three options that we give, but the most important is stage, and stage falls into category, option B, that is a distant metastasis. Question number 17. Okay? Again, it is on burns. Estimate the injury of the patient burns involving to the chest. So when you say chest, we talk about it. So it is not trunk, it is only chest. So chest is going to be 9%. Abdomen is going to be 9%. That is chest and abdomen together is trunk. We learn right upper limb. One limb is 9%. The whole of the right thigh. So break it down. Your lower limb is going to be 18%. In that, if you look at the thigh, in the below thigh, so we have thigh is present and you have knee and below. So I can say the lower half. Again, it is going to be 9% thigh, 9% lower half. So what is this? 9% here, 9 plus 9 is 18. 18 plus another 9 is going to be 27. 27 plus another 9 is going to be 36%. So answer here is going to be 36%. We already dealt with this question. Question number 18, this is your previous exam question. Obviously all of them are, but it is a recent one, last exam only. Open cardiac massage is what kind of wound? Remember, for a clean wound, the criteria is it should be number one, non-traumatic. Number two, it is going to be elective. And number three, there should be no entry into natural cavity. So when you look at the open cardiac massage is done as an emergency procedure. It is basically comes under re-exploration. Open cardiac massage are re-exploration, they are emergency. So obviously when you talk about elective, open cardiac massage cannot be a clean surgery. Now when you talk about contaminated surgeries, right? So for clean, then you go to clean contaminated, which is the next one. For a clean contaminated surgeries, again it should be non-traumatic. It should be non-traumatic. It should be elective. But here there is entry into natural cavity. There's entry into natural cavity. So this is your clean contaminated. Again, open cardiac massage is emergency, so it cannot be clean. It cannot be clean contaminated. For a dirty wound, it should have pus or fecal matter. So because it does not consist of pus or fecal matter, it cannot be dirty. By the virtue of this only, you can say that these are contaminated wounds. These are contaminated wounds. So what are contaminated wounds? What are contaminated wounds? For a contaminated wound, number one, it is fresh trauma or your fresh trauma, your emergency bowel surgeries, and all your re-explorations. All your re-explorations are contaminated. Hence, open cardiac massage by far becomes the contaminated wounds. Okay. Let's go to the next question. That is your question number 19. Now, what do you have? We have a female who is presented with non-palpable lump in the breast. Okay. The biopsy and IHC reveals luminal A. We have already discussed it. Luminal A is ER positive, PR positive, and HER2 neogene is negative, right? So ER positive, PR positive, HER2 not positive, ER positive, PR positive, HER2 negative with low proliferation, yes. High proliferation is Ki67 index. So Ki67 is low here, which is true. ER positive, PR positive, HER2 negative, high, no. Ki67 index for a luminal A is low. Triple negative is ER negative, PR negative, HER2 negative, it is wrong. Okay. So luminal A is going to be B for Bombay. It is going to be B for Bombay. Question number 20. A patient was admitted with parathyroid adenoma. After surgery removal, the correct gland can be confirmed by. Now, this is a question that they usually ask you on the basis of the Miami criteria. Now, what does the Miami criteria basically says? That you have to remove the patient's parathyroid gland. Okay? So, so the whole criteria is you have to see the parathyroid hormone pre-operative level. Parathyroid operative pre-operative level should be measured. Then you remove the diseased parathyroid gland. Remove diseased parathyroid gland, and intraoperatively during the surgery, intraoperatively measure parathyroid hormone level. Now this has to be measured 5 minutes after removal, 10 minutes after removal, and 15 minutes after removal. Now, how do you know that you have removed the right gland? So when you measure the parathyroid hormone after 5 minutes should drop, 10 minutes it should drop more, and 15 minutes it should drop even further. But what does the Miami criteria say is that it drop at the 10-minute point. This should be more than 50% of pre-operative value. This drop should be more than 50% of the pre-operative value, and hence it will satisfy the Miami criteria, and then you say that you have removed the right gland, right? So 50% reduction in parathyroid hormone within 10 minutes of the gland removal is the right answer. That is going to be your C for Calcutta. Going to question number 21. Regarding the retrosternal goiter, identify the correct statement from the following. Now, retrosternal goiter by the classification itself, if more than 50% of the thyroid gland, if more than 50% of the thyroid gland is below the neck level, this is what we call it as retrosternal goiter, right? Now remember, in retrosternal goiters, we have primary and secondary. Your primary and secondary. Primary arising from ectopic retrosternal thyroid gland. Secondary is normal thyroid gland. Normal thyroid gland extending into the thorax. Extending into the thorax, right? Now, when you look at the following, sternal incision is always required is wrong. We only do sternal incision if number one, there is recurrence. Indication for sternal incidence or incision is recurrence. If there is suspicious of malignancy. If there is suspicious of malignancy or it is a very large gland. Or it is a primary retrosternal goiter. So the indications of primary retrosternal goiter, recurrence, suspicious of malignancy, or it is a very large gland. Then you go with sternal incision. Otherwise, the standard is cervical incision. Majority retrosternal goiter can be removed by neck incision is correct. So which of the following? Identify the correct state. This is correct. Majority of the goiter derived the blood supply from mediastinal vessels. No, it has a normal. Your superior thyroid and the inferior thyroid artery. Operate only if symptomatic. No, you should be removing. If the gland is retrosternal, you should remove it. So answer here is going to be B for Bombay. Question number 22. The temperature for the frostbite rewarming. Now this is a repeat exam question. The temperature for the frostbite rewarming is 37 degrees Celsius. So the closest to the answer is going to be option C, that is 38 degrees Celsius. Core body temperature. Question number 23. During the parotid surgery, the following would not be the surgical landmark for the facial nerve. Now, the surgical landmark for the facial nerve, the first one is when you look at, okay, the multiple one, we look at the options and only give you the objective here. On the posterior belly of the digastric, yes, there's a tragal pointer which is around 1 to 1.25 centimeters below and medial to the tip of tragal cartilage, and this is also called as the Conley's point. Also called as Conley's point. So yes, this is also correct. Inferior belly of the omohyoid, yes, you trace the inferior belly, you will see the trunk of the facial nerve. Dissection from the peripheral nerve branches is wrong because peripheral nerve branches is going to be into the gland, right? And the trunk is present right at the base of it, so hence it cannot be the answer. So answer is going to be D for Delhi, which is not a surgical landmark, it is D for Delhi. Question number 24. I have a 42-year-old female admitted with a 4 centimeter breast mass on the upper outer quadrant. Biopsy was done, revealed densely packed cells along with the band of nuclei, and mucin was found infiltrating the stroma. What is the most likely diagnosis? Presence of mucin. Presence of mucin indicates it is colloid carcinoma. It is colloid carcinoma. So answer here is C for Calcutta. It's going to be C for Calcutta. 25. Again, this is a spotter. I have a 27-year-old male with 2 centimeter thyroid nodule. Thyroidectomy was done on HP. The image was given below. What is the most likely diagnosis? You see this particular image. Empty vacuolated cell with large nuclear to cytoplasmic ratio, and this is what we call it as the orphan ani nuclei. Your orphan ani nuclei, right? So when you look at the options, medullary cancer thyroid will present to you with amyloid in stroma. It is amyloid in stroma. For papillary cancer thyroid, they will have Samoma bodies. Along with Samoma bodies, they have orphan ani nuclei. Orphan ani nuclei. Samoma bodies, orphan ani nuclei, and grooving of cells. For follicular cancer thyroid, they have presence of, if there is a Hurthal cell cancer, they have oxyphilic cells and Ashkenazi cells, right? So here, because it is orphan ani, the answer is going to be C for Calcutta. It is a C for Calcutta, correct. Going to the next question, that is question number 26. Which of these is the most life-threatening injury that can be identifying the assessing? We have already done this question. I think it's a repeat one. So on the basis of breathing, cervical spine injury cannot be picked up. Tension pneumothorax, yes. Blunt cardiac injury cannot be done. Your tracheobronchial injuries, not laryngotracheal injuries. So answer here is B for Bombay. It's a B for Bombay, correct. Question number 27. I have a 32-year-old female with Graves' disease. The eye signs and the enlarged. So the presence of eye signs, there is enlarged thyroid, planned for total thyroidectomy, which can be given in a pre-operative period to reduce the intraoperative bleeding. So the anti-cancer thyroid drug that reduces the vascularity. So the anti-thyroid drugs reducing the vascularity of the gland. Reducing the vascularity of the gland are your thyroid constipating drugs. These are sodium iodide, potassium iodide, and Lugol's iodine. It is sodium iodide, potassium iodide, and Lugol's iodine. Sodium iodide, potassium iodide, and Lugol's iodine. So, yes, sodium iodide can cause not propanol, not propyl thiouracil, not beta-methazone. Answer here is going to be A, that is your potassium iodide. Okay. Chalo. Question number 28. Now, what is the correct sequence of managing the patient who presents to the casualty for road traffic accident? So, correct sequence is going to be A, B, C, D, E. Okay. Now, A is airway with cervical spine stabilization. Airway with cervical spine stabilization. So, no matter what, this becomes first. Next is breathing. So, it is breathing and ventilation. Now, in order to maintain the ventilation, you have to intubate. So, this is correct. Third is circulation. Now, in circulation, you will fluid. Okay. D is a disability, E is exposed exam, CT is in secondary survey. So, the last is going to be CCT. So, this is the correct sequence 1, 2, 3, 4. Right. So, correct sequence is 1, 2, 3, 4. Answer here is going to be B for Bombay. Chalo. Question number 29. So, we have a 49-year-old female with the breast lump. Which of the following findings is in accordance to the basal cell? We have already discussed this. Basal cell is also called as your triple negative. It is a triple negative breast cancer where ER is negative, your progesterone receptor is negative, and the HER2 neogene is negative. It is triple negative. So, all three of them are negative. Is C for Calcutta. It's just C for Calcutta. Going to question number 30. Which of the following is not a relative contraindication for breast conservative surgery? We've already discussed this in the previous section, that what are the contraindications or indications of breast conservative surgery. So, which is not a contraindication for breast conservative surgery. Now, if you look at the indications for breast conservative surgery, that will solve this question. Number one, I told you the size of the tumor should be less than 4 centimeters. It should be limited to 1 quadrant. It should be limited to 1 quadrant. The size should be less than 4 centimeters, limited to 1 quadrant, right? It should be limited to 1 quadrant. There should be absence of lymphovascular spread. No evidence of lymphovascular spread, right? It should be solitary. It should be solitary, and patient should be non-pregnant. Okay. So, these are the indications that you have. So, size less than 4 centimeters is an indication of breast conservative surgery with N1 axillary lymph node metastasis. So, he's asking not a relative contraindication. Okay, let's look at the other options. Tumor more than the size of the breast. Obviously, if it is more than 4 centimeters, you cannot do breast. See, if the size of the tumor itself is more than breast, how can you conserve breast? Common sense. Any history of previous radiation exposure indicates that whole breast itself is disease. You cannot conserve it. Multicentric tumors, that is presence of more than 1 quadrant. Again, not so. Giving all the options, the one that I feel that you can do a breast conservative surgery is your option A. Question number 31. So what do you have? I have a 37-year-old unmarried nulliparous woman. Okay, I think this is a repeat question. Regular intercourse, oral contraceptive, mother diagnosed with breast cancer, sister diagnosed with breast cancer. What should we advise her for genetic counseling? We have already spoken about it. Question number 32. A 34-year-old woman brought to the AIMS emergency after a road traffic accident. She was hemodynamically stable. GCS was 3. Okay. Intubated, sent for CT, found to be normal. Now, whenever you see a question like this is a condition called as diffuse axonal injury. Now, when you look at the diffuse axonal injury, here the patient is defined as complete disruption. This is a complete disruption. This is complete disruption of axons between white and gray matter. Between white and the gray matter. So, complete disruption of the axons between the white and the gray matter. In this, patient will land up with coma. The GCS of the patient, when you calculate, will be 3/15. The CT appears to be normal. So, here immediately get an MRI done and you will see presence of punctate hemorrhage. Presence of punctate hemorrhage between white and the gray matter. Between white and the gray matter. It's a punctate hemorrhage between white and the gray matter. Right? It is also a poor prognosis. So this condition, it is not subdural, not extradural. Yes, diffuse axonal, not cerebral contusion. Answer here is C for Calcutta. It is a C for Calcutta. Now going on to question number 33. A 25-year-old woman with the breast lump, no skin changes, okay, no induration. On histology, there is fibroadenoma appearance. Okay. Which of the following categories does it fall under? Okay. Now, when you look at the categorization, basically asking around BI-RADS, right? So it is breast imaging, reporting, and data system. Now, according to the BI-RADS, you have category 0, which is incomplete assessment. There is your incomplete assessment. Category 1, it is negative for any tumor. Category 2, it is 100% benign, do nothing. Category 3 is probably benign. Now, if they ask you what is the probability of malignancy, it is less than 2% chance of having cancer. So here, follow up after 6 months. That's your exam question. Follow up after 6 months. Category 4 is going to be suspicious of malignancy. Category 5 is highly suggestive of malignancy. And category 6, it is biopsy proven malignancy. It's a biopsy proven malignancy. Fibroadenoma is 100% benign. If it is 100% benign, then the answer is going to be category 2. So it is going to be BI-RADS category 2. It's the BI-RADS category 2. Clear? So this is your question number 33. Going on to question number 34. Which of the following is not a part of damage control surgery? Now, damage control surgery is basically performed. The goal for damage control surgery is to prevent lethal triad of trauma. To prevent the lethal triad of trauma. Now, when you look at the lethal triad of trauma, what comprises of lethal triad of trauma? Number 1, if there is metabolic acidosis in association with hypothermia, and coagulopathy. Hypothermia and coagulopathy. So how do you categorize it? So what are the various stages? So stage 1 of damage control surgery is patient selection. Now you need to understand which patient will require a damage control surgery and which will require an early total care. Stage 2 is primary exploration. Now the goal for primary exploration, it is to control hemorrhage. It is to control hemorrhage and prevent any further contamination. Prevent any further contamination. Prevent any further contamination. In primary exploration, there is temporary abdominal closure. This temporary abdominal closure. Then you have stage 3. Stage 3 is your ICU care, which is going to last for 24 to 48 hours. The objective of the ICU care, it is to treat coagulopathy, and prevent hypothermia. Right? Stage 4 is secondary exploration or re-exploration. The goal here, it is to correct the anatomy. After correcting the anatomy, I am not going to close the abdomen. Here also, temporary abdominal closure. So, temporary abdominal closure. The last one is stage 5. Stage 5 is your definitive abdominal closure. You want to be definitive abdominal closure, right? So question is, which is not a part. Control hemorrhage. When you look at the whole objectives, resuscitation, decontamination, obviously to prevent any further contamination. Vascular anastomosis is not, right? We try to salvage the conditions, not repair it. So hence answer is going to be D for Delhi. Okay. Question number 35. Yeah, most of you guys are giving right answers. I'm just going a little bit faster so that I don't consume a lot of time of yours and just give you a quick approach to the questions. That's the objective. Okay? A female patient presents with a lump in her breast. All of the following can be used to rule out the malignancy except. Okay, we're talking about ruling out the malignancy. Okay, with radiological investigations, I cannot confirm, but I can definitely rule out. Okay, that's a BI-RADS 0, BI-RADS 1, BI-RADS 2 gives you that. So radiological investigations, we have BI-RADS. And according to BI-RADS, if BI-RADS 1 and BI-RADS 2, you can rule out malignancy. PET scan, yes, it can give you an objective whether it's metabolically active or not. Clinical examination, you cannot rule out malignancy. Cytology histology are the gold standard, so you cannot question. So answer here is C for Calcutta. Okay? You cannot rule out malignancy. Question number 36. Mastectomy was done in a patient and the following drain was kept under the flap. The flap needs to be what you. Okay, so the drain that you're seeing, it is a Romovac drain. It's a Romovac drain. It's a negative suction drain. Now, because it puts on the principle of negative suction, this is called as an active drain system. Now, for any negative suction to work, it has to be a closed system drain. Because if it is an open, you will not be able to create an negative pressure. So it's a negative suction drain. It is on a closed principle. It works on a closed system drains, right? So the flap has to be closed, not semi-closed, not open, not semi-open. For this drain to work, it has to be closed. It has to be closed. Question number 37. Frozen section was done. Surgery of the breast carcinoma. Okay? Which of the following This would be useful for all of the following except. ठीक है. Now, frozen section is used for sentinel lymph node biopsies. Done for all, no, only those cases which are borderline suspicious. For example, phylloids, if it is suspicious, you're looking for sentinel lymph node biopsy. In all those cases, you can do it, but not required. For positive margins, yes, I would do frozen section to identify metastatic lesion. Yes, so not done for all cases. This is wrong. So option B is wrong. Looking at question number 38. A patient was admitted with carcinoma of breast, HER2 neogene, IHC staining. The following score will need the further study for FISH. Okay, that is fluorescence in situ hybridization. So when would you like to take the patient for FISH? If you have the scoring of HER2 neogene, somebody is giving me a right answer. If a score of more than or equal to 2, बेटा somebody is asking कि सर ट्रिपल एसएस में क्लिनिकल एग्जामिनेशन भी है. बेटा क्लिनिकल एग्जामिनेशन में आप मैलिग्नेंसी रूल आउट नहीं कर सकते, आप सस्पेक्ट कर सकते हो. ठीक है. रेडियोलॉजी में क्या है कि अगर आपने मैमोग्राफी की और कोई भी लीजन नहीं दिख रहा है तो उसमें कोई लीजन ही नहीं है, तो ऑब्वियसली इट इज नेगेटिव. ठीक है, तो रूल आउट तो कर ही दिया. अगर दिख भी रहा है बिकॉज ऑफ दी ऑल दी फैक्टर्स दैट वी हैव, योर रेडियोलॉजिस्ट माइट टेल यू इट इज कैटेगरी 1 और कैटेगरी 2. तो कैटेगरी 1 तो नेगेटिव है, कैटेगरी 2 क्या है, फाइब्रोइडोमा लाइक लीजन, सो इट इज एब्सोल्युटली बिनाइन. तो वहां पे आप रूल आउट कर दे रहे हो मैलिग्नेंसी को. पेट स्कैन में क्या है, अगर एक्टिव, अगर वो मेटाबॉलिकली एक्टिव है ही नहीं तो इट कैन नॉट बी ट्यूमर ओनली. अगर ट्यूमर ही नहीं है तो आप रूल आउट कर दोगे. तो यहाँ पे क्वेश्चन ये है कि क्या आप मैलिग्नेंसी रूल आउट कर सकते हो कि नहीं कर सकते हो, है ना. सो ऑब्वियसली clinical examination cannot rule out. You can suspect malignancy, आप rule out नहीं कर सकते. Question number 39. So in question number 39, a patient was admitted with the history of knife injury over his arm. ठीक है. The radial and ulnar pulse were not felt. It is found that the right brachial artery has a longitudinal cut of 2.5 centimeters. What is the ideal management? देखो अगर radial ulnar artery is not felt, that means the vascularity is compromised, so you have to go ahead and repair it. If you ligate the artery, obviously there will be no blood supply, it will become gangrenous, you cannot ligate the artery. ठीक है, so do not ligate the artery. Repair with saphenous vein graft. बेटा saphenous vein graft will only be used if there is loss of segment. यहाँ पे longitudinal slit है तो saphenous vein graft का तो बनता ही नहीं है, तो यहाँ पे ना ही patch बनेगा ना ही graft बनेगा. So here you have to go ahead with prosthetic repair. That is, put a prosthesis and repair it off. Only if there is a lost segment of the vessel, you'll go with saphenous vein. Question number 40. What do you have? A patient with a tibia fracture 1 month ago, ठीक है, with his cast, okay, cast was removed, a few ecchymosis were observed on the skin. After a few days, he came back with pain, okay, when lifting with his great toe. There's also decreased space. Both posterior tibial and the dorsalis pedis arteries pulsation were felt. Be needed, right? So when you compartment syndrome, right? So what is the compartment syndrome? If the pressure is more than 30 millimeters of mercury with signs and symptoms of neurovascular compression. So after you've put the cast and all, it usually. Now what do you have? A 30-year-old female admitted with bone pain, abdominal cramp, psychosis, history of renal calculi, everything is there. So basically it is a classical case of primary hyperparathyroidism. How am I saying it is primary hyperparathyroidism? In primary hyperparathyroidism, there is a classical pentad. So what do you have in pentad? Number one, there is presence of renal stones. There is painful bones. There's abdominal groans. So renal stones, painful bones, abdominal groans, psychic modes, and fatigue overtones. Right? So these are the features of primary hyperparathyroidism. Just to give you objective, the investigation of choice for primary hyperparathyroidism is your SISTA maybe scan. If they ask you what is the best investigation, answer is 4D CT. Management, if it is adenoma, then adenectomy. If there's a parathyroid adenoma, then you have to do adenectomy. And if it is parathyroid hyperplasia, if it's a parathyroid hyperplasia, then it is 3.5 surgery. And it is 3.5 surgery. Okay? So here the question says that on evaluation, multiple fractures, okay, painful bones are there. Both serum calcium and parathyroid hormones were found to be increased. The best investigation, best is asking is going to be 4D CT, not ultrasound, not PET scan, not MRI here. So the only option that I have left out with system may be scan. So the best is going to be 4D CT. It is 4D CT, right? Just in case you know the difference between primary and secondary, in primary hyperparathyroidism, the calcium and parathyroid both will be high. In secondary hyperparathyroidism, the calcium will be either low, normal, but parathyroid will be high. Okay? That's a question number 41. Going into question number 42. A 38-year-old female admitted with right breast lump, upper outer quadrant with negative axillary lymph nodes on the same side. Mammography reveals BI-RADS 4, right? We have already discussed BI-RADS 4. Okay? Breast conservative surgery was done. Patient HP report diagnosis of ductal carcinoma in C2. The next step would be, now the patient has undergone a breast conservative surgery and it is a DCIS is present. Okay? Now, if it is carcinoma in C2, in a breast conservative surgery, you have to give radiotherapy, right? Without radiotherapy, it is not complete. So yes, radiotherapy will be given, not chemo. Trastuzumab is only given if it is HER2 neo positive. Follow-up 6 monthly for 2 hours is correct, but then what have to be done without giving radiotherapy does not work out. No. So answer here is going to be radiotherapy. Breast conservative surgery, it has to be with radiotherapy. It has to be with radiotherapy. This is a repeat question. What does triage mean? Triage is a color coding system. It is a color coding system. Now, on what basis are you going to code the patient? So, on a color coding system, I know everybody knows that there are the code red is there. There is code yellow. Then you have code green. Now you have code blue also. And the last one is black. Now this is a sequence of importance, right? Least is black, most important is red. Now this system or coding system is done on the basis of, number one, it is done on the basis of outcome when compared to severity. Number two, it is also done on the basis of resources required versus resources available. It is resources required versus resources available. Okay. Okay. So triage, does it mean to classify? No. It basically means to arrange, that is to sort out, not to investigate, not to rehabilitate. The answer here is B for Bombay. It is basically sorting out the patient on the basis of outcome and the resources required versus resources available. Next one, question number 44. The most common tumor of the lacrimal gland would be, the oral most common is going to be pleomorphic adenoma or adenocarcinoma. That's a repeat question, not important. Okay. Question number 45. Now it says a 49-year-old female with thyroid swelling in front of the neck moves on deglutination. Ultrasound, a large nodule taller than wider, okay, with microcalcification, irregular margin. All these are pointing towards malignancy. in the right lower thyroid gland is seen. Their enlarged cervical lymph nodes are present on the right side. FNA of the thyroid nodule is advised. Appropriate FNAC specimen. So they are asking for optimum cytology criteria. They are asking for optimum cytology criteria. Now to get an optimum cytology, first the size of the needle. It should be between 22 to 26 gauge needle. Single best answer is 23 gauge needle. There should be a minimum of 2 aspirate. Each aspirate should consist of minimum 6 follicles per aspirate. And there should be at least 10 to 15 cells per follicle. If all these are satisfied, then we say it is going to be optimum cytology, right? So when you look at the options, 3 follicles is wrong, 6 follicles is correct, containing 10 to 15 cells, each, not well preserved, something is written here. 10 follicular groups, no, 6 to 8 follicular groups, okay, with 10 to 15 cells each with well preserved, yes, answer is D for Delhi. It is going to be D for Delhi. So going on to question number 46. Now in question number 46, what do you have? A 23-year-old male presents to the accident and emergency with burns from bursting of stove. Okay. After initial resuscitation, patient is examined thoroughly. On examination, burns to his face. Face is going to be 9%. Burns cover the whole of the chest, abdomen. Okay, chest and abdomen is 18%. Whole and the front of both arms. So both arms only front means half and half. That is 4.5% on left, 4.5% on right. So together it is 9%. What would be the percentage? So 9, 8, okay, 9%, 18 is 36%. So answer here is going to be B for Bombay. It is a B for Bombay. Question number 47. I have a 51-year-old female brought to the emergency department unconscious, okay, after a road traffic accident. She is afebrile, blood pressure is very low, pulse is high, respiratory rate is low, GCS has fallen, reveals multiple injuries and massive blood loss from the deep cut on the right upper quadrant of the abdomen, suggesting trauma to a vital organ. The focused assessment, the FAST was done. In the FAST, which are the following can be evaluated, right? Now, for a FAST, 80 ml cannot be, it has to be a minimum of more than 100 ml, you cannot evaluate it. Retroperitoneal hemorrhages, because the bowel is present, retroperitoneal organs cannot be evaluated well on ultrasound because of bowel shadows. Stomach injury, it is hollow viscous, cannot. Yes, solid organ injuries can be evaluated on FAST without any problem. So answer is liver injury. Question number 48. For a full thickness and a split thickness skin graft, the correct statement is, right? Now, when you talk about, the question is about contractures. In the graft contracture, for a graft contracture, there are 2 contractures, the primary and the secondary contracture. Now, remember, for split thickness, it is secondary more than primary. For full thickness, it is primary more than secondary. Now, because of this, it is poor cosmetic outcome. And here full thickness is a good cosmetic outcome. Is a good cosmetic outcome. Okay. Now they are asking that the correct statement, which of the following is a correct statement. Now the first one is primary contracture is more with split thickness is wrong. Secondary contracture is more with split thickness is correct. Primary contracture is more with full thickness is correct. Secondary contracture is more with full thickness. It is wrong. So 2 and 3 are correct. So 2 and 3 is option C. So option C is correct. Question number 49. So we've done a total of 50 questions. So it is a 49. We have one more question to go. The graft is taken from an identical twin. It is known as. Now let's try to understand. Autograft is from same person. Isograft is from identical twin. So we got our answer. Isograft is from identical twin. Allograft is from same species. Xenograft is from cross species. So answer here is B for Bombay. The last question for today is this, question number 50. All of the following are included in the primary survey of ATLS except, we have already done that. X-ray will be done, FAST will be done, chest X-ray can be done, CT is not done. Answer here is D for Delhi, right? So these are the set of your INI PYQs that you're supposed to know, right? I'll be sharing with the PDF on our MedEd group as well. Just go access it there. For the INI CT, remember, if you look at the last 5 sessions, a lot of questions from pure general surgery are there. Systemic surgery weightage is slightly lesser, but the questions has been consistent between 15 to 20 questions per session. That is bare minimum you're getting. On a good day, you get 25 questions in general surgery. Please revise your previous year topics of last 5 sessions. You will have most of the questions from there. Stick to the basics, revise at this point, do not add anything new, and do as many questions as possible. You are going to write 200 questions exam. So hence the daily practice of questions has to be minimum 200. If possible, double it to 400 per day from now onwards so that you feel confident on the day of the exam. Thank you so much. Have fun. We'll see you on the other time.